Good morning, everyone, and thank you for being here today. I'm Dr. Asim Haseen, and I'm delighted to welcome you to this session on endocrine and metabolic emergencies. Today, we're going to focus on a very important topic, severe hypertriglyceridemia-induced pancreatitis. Over the next few minutes, we'll explore the causes, clinical features, and management strategies for this critical condition. I look forward to sharing insights and engaging with you all as we deepen our understanding of this complex emergency. Let's get started. Let's look at the question here. We have a 44-year-old patient presenting with severe epigastric pain and a history of hypertriglyceridemia. His serum triglycerides are markedly elevated at 1,800 mg/dl, which is about 20 mmol/L. Additionally, his amylase is modestly elevated. Now, the key question is, what best supports the diagnosis of hypertriglyceridemia-induced pancreatitis? Looking at the options, the most relevant one is answer E. Triglycerides greater than 1,000 mg/dl, along with a compatible clinical picture. This is important because, in cases like this, extremely high triglyceride levels, above 1,000 mg/dl, are well known to be a precipitating factor for pancreatitis. The clinical presentation aligns with severe epigastric pain, and the labs support this. The other options, such as elevated bilirubin or amylase alone, are less specific for this diagnosis. Elevated bilirubin confirms cholestasis, but doesn't necessarily point to pancreatitis caused by hypertriglyceridemia. An amylase over 1,000 could be specific, but in hypertriglyceridemia, amylase can be only modestly elevated or even normal, so it's not the best standalone indicator. And importantly, a normal lipase tends to exclude pancreatitis, but here, the lipase isn't mentioned as normal. So, the most supportive evidence remains the triglyceride level in conjunction with the clinical picture, making answer E the best choice. Let's look at the correct answer here, which is E now. The key point to understand is that when triglyceride levels are very high, specifically, over 1,000 mg per deciliter, which is approximately 11.3 mmol per liter, this can lead to pancreatitis. Often, levels are even higher, exceeding 1,500 mg/dl. When we see these elevated triglyceride levels, along with clinical signs of pancreatitis, it strongly supports the diagnosis of hypertriglyceridemia-induced pancreatitis. This connection is important because it guides us toward targeted management strategies. So, to sum up, extremely high triglyceride levels combined with symptoms of pancreatitis are a hallmark for diagnosing this particular cause, emphasizing the need for careful lipid assessment in these cases. All right, let's take a closer look at this question. We have a patient with a triglyceride level of 2,500 mg/dl, which is quite high, and they're suffering from severe pancreatitis along with multi-organ dysfunction. The key here is to identify the emergency therapy that can rapidly lower triglycerides in such critical situations. Now, among the options, high-dose IV insulin infusion with or without glucose is known to be effective in acutely reducing triglyceride levels, especially in severe cases. It's a quick, targeted approach that can have a significant impact. On the other hand, oral fibrate therapy alone is more of a long-term management strategy and isn't suitable for immediate intervention in a severe, life-threatening scenario. Immediate plasmapheresis or apheresis can also rapidly lower triglycerides and is often considered in refractory or emergency cases like this. IV heparin bolus alone isn't typically used for triglyceride reduction. It's more for anticoagulation purposes. And starting octreotide infusion is more relevant for certain endocrine emergencies, such as bleeding varices, rather than triglyceride management. So in this case, the most appropriate answer for rapid triglyceride reduction in a severe, refractory situation is high-dose IV insulin infusion, possibly combined with glucose, to quickly bring down those triglyceride levels and help stabilize the patient. The correct answer here is C now. Let's talk about why. Plasmapheresis is a rapid and effective way to lower triglyceride levels because it physically removes triglyceride-rich lipoproteins from the blood. This makes it especially useful in severe cases of hypertriglyceridemia-induced pancreatitis that are resistant to other treatments. It's particularly indicated when there's organ failure involved, as time is of the essence in these critical situations. On the other hand, insulin infusions can also help lower triglycerides, but they work more slowly because they promote the activity of lipoprotein lipase, which takes some time to clear the triglycerides from the bloodstream. So, in urgent, severe cases, plasmapheresis is generally the preferred approach for rapid reduction. This ties into our overall theme of managing hypertriglyceridemia effectively, especially when complications like pancreatitis become severe. All right, let's look at this scenario. A diabetic patient presenting with a triglyceride level of 1,400 mg/dl and pancreatitis, but they are hemodynamically stable. The question here is, what is the most reasonable therapy in the ICU setting to lower triglycerides if plasmapheresis isn't immediately available? Now, among the options, we need to think about what makes sense clinically and what's feasible in this situation. Option A suggests an IV insulin infusion with dextrose to drive lipoprotein lipase activity. This approach is often used because insulin helps activate lipoprotein lipase, which in turn helps clear triglycerides from the bloodstream. So, insulin infusion can be a quick and effective method, especially in diabetic patients. Option B is heparin infusion alone. While heparin can temporarily increase lipoprotein lipase activity by releasing it from endothelial stores, its role as a sole therapy is less established and can carry bleeding risks, especially in pancreatitis. Option C recommends high-dose statins immediately. While statins are great for lowering LDL cholesterol, they are not the first-line agents for acute triglyceride lowering, especially in this emergency setting. Option D is oral omega-3 fatty acids only, which are helpful for triglyceride management, but generally take longer to have a significant impact, and they are not ideal as the sole immediate therapy in an acute setting. Finally, Option E suggests waiting and observing the triglyceride trend. But given the severity of hypertriglyceridemia and pancreatitis, waiting could risk worsening the condition. Considering all this, the most reasonable immediate intervention in this scenario would be the IV insulin infusion with dextrose to actively lower triglycerides quickly and safely while monitoring the patient closely. This approach aligns with the overall theme of managing hypertriglyceridemia in acute settings, especially when more invasive options like plasmapheresis are not immediately available. The correct answer here is A. When managing severe hypertriglyceridemia, insulin plays a crucial role because it activates lipoprotein lipase, or LPL, which helps break down triglycerides in the blood. This process effectively reduces triglyceride levels. Now, it's important to remember that when we give insulin, we also need to provide dextrose. Why? To prevent hypoglycemia, of course, because insulin lowers blood sugar levels as well. Some might wonder about heparin, which can temporarily release LPL into circulation. While that might seem helpful, it actually carries risks, especially bleeding, and isn't considered a standalone treatment for hypertriglyceridemia. So, in summary, insulin combined with dextrose is our mainstay for rapidly lowering triglycerides, and we avoid relying solely on heparin because of its risks. This approach ties into the overall theme of targeted, safe management of lipid abnormalities. Now, let's consider the best long-term approach after we've achieved acute stabilization and the patient's triglyceride levels have dropped below 500 mg/dl. The key question here is, what is the most appropriate therapy to prevent recurrence of hypertriglyceridemia? Looking at our options, we want to focus on strategies that are both effective and sustainable over time. Option A suggests continuing only dietary advice, which is important but might not be sufficient on its own to prevent future flare-ups, especially in patients with severe hypertriglyceridemia. Option B recommends starting medications like fenofibrate or gemfibrozil. These are fibrates, and they are well known for their ability to lower triglyceride levels effectively. They are often used as a mainstay in long-term management. Option C suggests that no therapy is required, but that's generally not advisable in cases where triglycerides are significantly elevated, even after stabilization. Option D involves lifelong insulin infusion, which is mainly reserved for cases of insulin deficiency, such as type 1 diabetes, and not specifically for triglyceride management. Lastly, option E proposes immediate high-dose niacin only. While niacin can help raise HDL and lower triglycerides, using it as the sole therapy immediately after stabilization isn't typically the most effective long-term strategy. So, considering all these points, the most appropriate choice for long-term prevention of recurrence in this scenario is to start fibrates like fenofibrate or gemfibrozil. They target triglycerides effectively and are a cornerstone in managing severe hypertriglyceridemia over the long haul. The correct answer here is B. Fibrates are actually considered the first-line long-term therapy for lowering triglycerides and preventing recurrence. This is a key point because managing triglyceride levels effectively helps reduce the risk of cardiovascular events over time. It's also important to remember that while fibrates play a central role, omega-3 fatty acids and lifestyle modifications are also crucial components of comprehensive care. Combining these approaches ensures a more effective and sustainable strategy for patients with hypertriglyceridemia. So, always keep in mind that a multifaceted approach yields the best results in long-term management. Now, let's look at this question about a patient with hypertriglyceridemia induced pancreatitis who is undergoing plasmapheresis and insulin therapy. The key here is understanding which complication we need to monitor closely during this treatment. The options are hypocalcemia and necrosis related to pancreatitis, hypertension, hypernatremia, polycythemia, or elevated platelets. It's important to recognize that during plasmapheresis, especially when treating hyperlipidemia, hypocalcemia can occur because calcium binds to the citrate used during the procedure, which can lead to symptoms like muscle cramps or even cardiac issues if not monitored carefully. While hypertension and hypernatremia are also concerns in various settings, they are less directly related to plasmapheresis in this context. Polycythemia and elevated platelets are more associated with blood viscosity issues, but they are not the primary concerns here. So, the most critical complication to watch for during plasmapheresis in this setting is hypocalcemia, which can lead to necrosis if severe and untreated. This highlights the importance of close monitoring of calcium levels during the procedure to prevent serious adverse effects. The correct answer here is A when dealing with hypertriglyceridemia-induced pancreatitis, or HTG pancreatitis. One of the key issues we need to watch out for is hypocalcemia, which is often caused by saponification. This process happens when calcium binds with fatty acids released during pancreatic inflammation, leading to calcium depletion in the blood. It's also important to recognize that HTG pancreatitis can put patients at risk for more severe complications like necrosis and multi-organ failure. So, during therapy, we really need to monitor electrolytes closely, especially calcium levels, as well as overall organ function. Keeping a close eye helps us catch any deterioration early and manage complications effectively. This underscores the importance of comprehensive monitoring in managing pancreatitis caused by hypertriglyceridemia. Thank you so much for your time and attention today. I really appreciate the opportunity to share these insights with you. Remember, the key points we've discussed, whether it's the importance of innovation, collaboration, or continuous learning, are all essential to driving success in our field. I hope you found this presentation helpful and inspiring for your own work. If you have any questions or want to discuss further, please feel free to reach out. Thanks again for being such an engaged audience.